Hello everybody, and welcome to this UCB sponsored symposium. Our goal is to introduce you to the toolkits that Paul Mitchell has written on behalf of FFN, one clinical and one policy. And we want to introduce you to their content and their rationale, and then describe how they can be employed to improve the quality of care that we give to our patients. Paul has been involved in FLS developments for at least 20 years, from both sides of the industry side and the medical side, and probably knows more about the whole business of FLS than anybody else in the world. Kasim Javed is an academic rheumatologist from the University of Oxford, and he is the chair of the Capture the Fracture steering group in the International Osteoporosis Foundation. And his colleague Andrew Gregg, Andy, is an orthopedic surgeon from the northeast of England, those two between them are the co-chairs of a project to improve FLS across Europe, which is called the European FLS Academy. And you'll hear all about that in the discussion afterwards. But first of all, the focus is on the toolkits, and I'd like to hand over now to Paul to give us his talk before we have a panel discussion.
Well, thanks very much, Dave, and thanks to everyone who's online. I'm going to share my screen in a moment. Because I know we're going to have an awful lot of discussion after this presentation, I'm going to do my thank yous up front so that no one is left out here. So big thanks to Dave Marsh, the founding father of FFN, for chairing this session. As Dave has mentioned, Kasim and Andy are co-chairs of this European FLS Academy network. So these guys have tremendous experience, and Cass has been involved in this area as long as I have, and so enormous experience there. I want to thank the numerous FFN colleagues who have provided input to the clinical toolkit, and associates of the FFN, and Kasim has done that as well, which really dramatically improved the quality of the document. Now let me share my screen with you. Okay, let's share that. Splendid, and let's just reduce the size of the thumbnail. Perfect. Okay, so let's go into slide share mode now, and I'll talk you through if it will work. Beautiful. So the topic of this talk is called, I've got a slightly catchy theme: IQ driving QI, systematically improving the quality of care we provide to people who sustain fragility fractures. Now, the IQ driving QI little expression there, I want to credit the Asia Pacific Consortium on Osteoporosis, and particularly my friend Dr. Manju Chandran from Singapore. That's an expression that we've used in several APCO publications. And what it's saying is intelligence quotient driving quality improvement, or using your smarts to drive quality improvement. And that's what I really hope we have tried to embed in the clinical and the policy toolkit. Also, a big thanks to UCB for supporting this symposium, and with their partners Amgen, and for the Ogilvy team for teaching us how to use the platform properly. Okay, here are my disclosures. Just want to make all of those clear, which say that Paul works with lots of different groups, and in this regard, I'm one of the ExCom members of FFN, and I'm the chair of the communications committee of the Fragility Fracture Network. Okay, Dave, Kasim, and Andy's disclosures are there. Right, so anybody who's been involved in this meeting this weekend will be very, very familiar with the global call to action on fragility fractures. This was published back in 2018 in the journal Injury, and was a major collaborative effort that started back in the Rome FFN meeting in 2016, where the leadership of FFN got together with the leadership of IOF and 4 other societies to say, look, we've all worked incredibly hard over the preceding years to try to improve various aspects of fragility fracture acute care and secondary prevention and rehabilitation. but there wasn't enough progress as far as we were all concerned. Thus, this group came together to write this global call to action, which said there's an absolutely urgent need to improve the acute multidisciplinary care of people who sustain serious fragility fractures that result in hospital admissions, that we need to do effective rehabilitation to restore function every time. And in addition to that, it's absolutely imperative that we do secondary prevention after the occurrence of all fragility fractures. And that includes both younger people and older people. And it also includes both the osteoporosis care aspects and preventing people from falling over. Okay, so 2 years on from the publication of the Global Call to Action, which was very broadly endorsed, as I think everybody knows, on publication, 81 societies from around the world had endorsed the call to action and committed to support its implementation. Now we're at about 130 endorsing societies. So there's a real groundswell of support around the world for seeing this call to action implemented. So about a year ago, during the Oxford Congress, the leadership of the FFN had various discussions to say, right, what comes next? And we decided that we needed to really articulate some practicalities about how this global call to action can be implemented. To achieve that, we envisaged that we needed to create 2 toolkits. The first one you're looking at here is the so-called FFN Clinical Toolkit. The purpose of this is to support colleagues across the world to be able to implement those 3 so-called clinical pillars of the call to action: great acute care, great rehabilitation, great secondary prevention. And this goes into some real practical detail. For each of the 3 pillars, there's a standardized structure to each chapter, which looks at a very top-line summary of the clinical and cost effectiveness of, be it orthogeriatric models, multidisciplinary models of rehabilitation, or fracture liaison services, post-fracture care models to deliver secondary prevention. We look at how those services are organized. Critically, there's an evaluation of pathway mapping, and FFN is in the process of developing a suite of tools that we hope to launch early next year to be able to electronically map pathways. In the interim time, we have links to some other very nice resources developed elsewhere in the world where this can be done in the old school style with big charts and paper pathways. If you don't know your pathway, then you're not going to be able to drive quality improvement. That's absolutely critical. We're going to look at this in these slides in detail, articulate what we have described as a stepwise approach to implementation. If on the first day that somebody has decided, for example, they want to devise a fracture liaison service, it can be overwhelming if one tries to achieve a super high performing fracture liaison service covering all types of fragility fractures from the get-go. So we've tried to break this down into manageable chunks. More about that in a moment. There are then sections for each of the pillars on benchmarking, which relates to clinical guidelines, standards, and registries. Then follow a summary of patient-reported outcome measures, and then a bunch of resources to support implementation, which have been developed by a number of groups across the world, and resources to inform patients of why this should matter to them. And I just want to acknowledge here that this toolkit was funded via an unrestricted grant from UCB, which we're very appreciative of, but its content was completely independently developed by the FFN, and FFN has maintained complete editorial control of that. Right, so clinical pillar 3. So this is talking about delivering secondary prevention in a reliable fashion after every fragility fracture. There are systematic reviews, which you can see at the bottom of this slide, which have clearly shown that the fracture liaison service model leads to improvements in various aspects of the process of quality of care, and significant reductions in overall costs of care, and emerging evidence on reductions in refracture rates as well. Back in 2013, my colleague Kirtan Gander from Sydney and Australia, and a bunch of other colleagues in Australia, classified different types of FLS according to this scale that you can see here, the type A through the type D. And the I's that are referred to here, the 3I, the 2I, the 1I, the 0I, relate to the tasks which the FLS personnel actually undertake. So the type A, the 3I model, FLS personnel identify patients, they organize their investigations, and they initiate whatever treatments or referrals to falls prevention services are required. That's quite an intense model. The type B, the FLS personnel undertake identification and investigation. However, they rely on a primary care provider, a primary care physician, to initiate the treatment recommendations. The type C is somewhat less intense still, where the FLS personnel identify patients. They also do another I, which is inform patients or educate them on why secondary prevention matters. But the investigations and the initiation of treatment is to be done by the primary care provider. And then the somewhat uncharitably titled type D 0I FLS suggests it doesn't do anything at all. This is just very much providing a bundle of education to patients and leaving the patient to then seek support from their primary care provider. What is clear from meta-analyses based on this categorization system is the type A and the type B models outperform the less intensive models in terms of the proportion of patients who get a BMD test and the proportion who end up on osteoporosis treatment. Okay, so with that in mind, and another key thing I should say to that previous slide is we note the type A and the type B models are more likely, quite considerably more likely, to have a dedicated fracture liaison coordinator managing much of the day-to-day work of the FLS. Something, as I alluded to at the beginning of this talk, that we have done in the clinical toolkit is to describe 3 stages of implementation that colleagues may be at around the world. And broadly speaking, this is how we see it based on collective experience from many years and the experience of colleagues who've developed programs across the planet. People are in 1 of 3 stages. They're at what we've called the preparatory stage, which means currently there's no systematic approach to deliver secondary prevention in place in their institution. There's no FLS. And the key question for those colleagues are, where do we start? Where do I start? This is a huge job. What do you want me to do? The expansion stage, which is you've run some kind of pilot program for 6 months, maybe a year. Where do you go from here to make this a more robust program where you're looking for funding for a 2 to 3 year period? And then the so-called sustainability phase, which is how do I embed this fracture liaison service into the DNA of my hospital? How do I ensure that there's permanent funding? And we've looked at each of the 3 clinical pillars from this perspective. For the purposes of this talk, we're going to focus on pillar 3, the secondary fracture prevention piece. Okay, so what we have articulated in the clinical toolkit is a playbook, if you like, a set of sequential steps that based on very broad experience can result in success. And this is for each of the different classifications of preparatory, expansion, and sustainability. One of the most critical things that anybody who's established an FLS anywhere knows is, to begin with, you've got to have a lead clinician for osteoporosis. Who is going to be the champion for FLS in the particular institution? Which type of specialist, that lead clinician, that first individual who says, I want to implement an FLS in my hospital, is going to be varies. In some situations, it will be an endocrinologist or a rheumatologist. Elsewhere, it might be an orthopedic surgeon. Certainly in the Asia Pacific part of the world, we see quite a lot of that. Or it could be a geriatrician or indeed other colleagues. But what is absolutely clear from all of the learned experience is that if an individual tries to go it alone without forming a multidisciplinary team, more often than not, that's not going to work out well. And so one of the very first jobs, and we state this very clearly in the toolkit, for that lead clinician within the institution is to assemble a multidisciplinary team of champions in all of the relevant specialties, clinical specialties, Also, one needs to cultivate champions in hospital administration, because that's ultimately where funding is going to come from. Hospital information technology, there are going to be information technology requirements. So if there's, one of the key steps in the preparatory phase is get yourself a multidisciplinary team together. And critically, something that Kasim and Andy have really advocated very strongly is one should invite patients and carers actually to attend some of those meetings, so that the services can be devised in a fashion that is going to be appropriate for the users of the said service. A next key step in the preparatory phase is what's the scope of the FLS program? Which patient group are you going to start with? We've been running the regional expert meeting in Asia Pacific this last 2 days. There's a meeting going on in parallel in Latin America. What we have tried to do with these toolkits is to say that to make them of use to colleagues who are in high resource settings, middle resource settings, and low resource settings. And therefore, when one is at the beginning of this quality improvement journey, do you try to take on every fracture type first? If you have the will and you have the way, well, I wouldn't want to inhibit that. But in reality, we have seen that many of the best fracture liaison services in the world started with the hip fractures. They then expanded to patients who were managed as inpatients, perhaps some of the humerus and the pelvis fractures next, and then moved into the outpatient setting. And with all those things done, then maybe move into the vertebral fracture setting. But in this preparatory stage, it's really important to say, this is the patient group we're going to focus on, and do that well. Okay, this is a bit of a busy slide here. This comes down to this business of mapping current pathways of care. If you don't know how a patient rattles through the hospital system, then one is not in a very good position to say, how are we managing patients currently, and where is there scope for improvement? As I've said, FFN is in the process of developing some, what I hope will be very useful electronic pathway mapping tools for next year. In the meantime, on the resources part of our call to action website, there are some visual old school tools for mapping out pathways. Pathways are going to vary by the fracture type, that's obvious. By musculoskeletal service configurations, which are going to vary between countries and within countries. More generally speaking, how urgent care services are configured. Urban versus remote and rural is going to present a challenge. How national health systems are funded and organised themselves, and the key issue of affordability for patients to receive fracture care, which may be a major challenge in some of the lower and middle income countries. A key step in this pathway mapping exercise is going to be to determine what's the best environment for identifying patients. Initially, it may be on the wards, and then moving into the ED and the outpatient fracture clinics. What is self-evident is that pathways are complex. And a galvanizing moment for one of the multidisciplinary teams, and we've seen this in lots of educational events, is actually to say, how do patients move through this complex healthcare system that we have to determine where there are opportunities to make improvements on the status quo? Okay. In the preparatory stage, we make a case to benchmark services against a clinical standard. Now, ideally, all countries in the world would develop their own clinical standards for secondary fracture prevention, indeed for acute care and rehabilitation. And there are various projects going on. The FIRMAT project in Oxford is looking to facilitate that. Right now, there are clinical standards that have been produced by the International Osteoporosis Foundation. Prof. Javad can talk about that more in the panel discussion. There's an excellent set of KPIs which can really help new and established FLS to get off the ground. There are some individual national clinical standards that have been established. Something that a philosophy that we have proposed within this clinical toolkit is at the preparatory stage, pick a clinical standard, maybe pick some of the individual components of one of those clinical standards and say, right, I'm going to benchmark what we're doing right now over a short period of time, perhaps a 1 to 2 month short-term audit which could be done prospectively or retrospectively through hospital chart review, to get a handle on how is secondary preventive care being delivered in your institution for a specific group of fracture patients, as benchmarked against one of these well thought out clinical standards. Another tool that we propose that one can utilize in the preparatory stage of trying to establish a pilot FLS program is to use tools like SWOT or the 5 Whys to understand where challenges emerge right now and how you might address them. So the SWOT tool, many of you will be aware of, is to take an overview of your current pathways of care, current deliveries of secondary prevention, where are the strengths, where are the weaknesses, where are the threats, where are the opportunities, or in parallel, the 5 Whys idea, which essentially says you define a problem and then you say, why does this care gap exist? And you ask the why question 5 times to really get to the root cause of what the issue is. So there is reference to those tools in the preparatory stage. Continuing on here with steps to establish a pilot program, consider what resources you currently have and how these might be reconfigured or redeployed to improve the current delivery of care. In Thailand, for example, a couple of years ago, there were major workshops done there as a big collaborative effort. Teams were mapping out their pathways and said from the perspective of current people that they have in place, current processes and current technology, what reconfigurations or refinements could be achieved to improve secondary preventive care during this preparatory pilot phase. And then once you've done all of that, then run a pilot project. And you don't need to run this for years and years and years. Define a specified period where you think we can get a meaningful handle on, is our new proposed model of care, our pilot project, improving outcomes for people who sustain fragility fractures for a 3 to 6 month period. Okay, then once you've done that, so picture that 3 to 6 month a period of testing a pilot service, we then move to this expansion stage. One of the key first things to do in the expansion stage is to say, well, look, we've done this pilot program for 3 to 6 months. What were the strengths, weaknesses, threats and opportunities identified there? So conduct the SWOT analysis. At this point in time, and bearing in mind, we would have intended to engage all of the clinical specialties in the multidisciplinary team, but also the hospital administrators, the potential payers. At this point in time, one needs to say, do we want to expand the scope of the FLS? If we started with just hip fractures, do we want to expand that scope to include other groups? And then revisit the pathways for the patients in the expanded scope to say, where can we best identify them? And ask this question again, what resources, new resources will we need in terms of people, processes and technology to deliver better secondary preventive care? And develop expanded program protocols that again align. If you have chosen a set of clinical standards to benchmark against, then for your expanded program protocols, say, how can I adhere to the quality standards that are advocated within my chosen clinical standard? Another key question is how you're going to deliver long-term follow-up here. Will that be delivered by FLS personnel? Will it be delivered by primary care providers? It's going to be different in different countries. Okay, so I'm going to accelerate a little bit in the interests of time now. We have developed a generic business case, which is probably best used at this expansion stage for FLS. It might inform people at the preparatory stage, but this is really trying to make the case for a 2 to 3 year period. You can download this from the resources part of the call to action, part of the FFN website, and they're embedded in the philosophy of this business case is that over a 2 to 3 year period, one conducts continuous quality improvement, iterative cycles, so-called plan, do, study, act. Decide what you're going to do to refine particular aspects of care delivery, do it, analyze it, decide what changes are required, and then iteratively go around that cycle. Many of the very well-established FLS have done this almost on a 6-month or 12-month basis in perpetuity. Okay. A key component of the expansion stage will be reporting on quality improvement and then spreading that word. Producing annual program reports for funders will be imperative to justify one's existence and demonstrate ongoing improvement. There is the opportunity for organizational reputational advantage there, which may drive opportunities for increased funding and to expand the program yet further. We'll talk a little bit more about fragility fracture registries in the panel discussion. Consider at this stage how there might be opportunities for networking. Well, the Fragility Fracture Network is a great opportunity for networking and indeed mentorship. So the FFN has a special interest group on secondary fragility fracture prevention. So if you're interested in this, look at the secondary fracture prevention SIG part of the website, consider joining that. Similarly, the vertebral fracture SIG website. Think about some of the personal and professional networks that you have. In the Philippines, for example, our colleague Iwin Tabu there expanded the group of hospitals that were implementing FLS through his Medical Alumni Society from the University of Manila. Also, and Professor Javad will talk about this, IOF Capture the Fracture Partnership has a major plan for a mentorship program around FLS, which will be rolling out over the next year. We can talk about that more. During this expansion phase of an FLS, this would be a perfect time to consider submitting your FLS for IOF Capture the Fracture best practice recognition. Yeah, and there are currently 360 odd FLS on the map, and the Capture the Fracture Partnership Initiative wants to double that and improve the quality of those. The sustainability bit is now, so the third phase, if you like, of okay, you ran a pilot program, the preparatory piece, you then consolidated your gains there and expanded the scope of the service and found interim funding for a 2 to 3 year period. Where do you go from here? This is about developing a longer term business plan to really embed FLS in the DNA of the institution. And key questions need to be answered there. Based on your 2 to 3 year experience, what is the readmission avoidance going on in terms of bed saves, bed days saved, and what cost savings have been incurred within the health system, and which function in the system is the principal beneficiary. As I've said before, this notion of continuous quality improvement in the sustainability phase, perhaps at the end of the expansion phase, consider publishing your work, submitting this to journals and presenting it at regional and international conferences. As I've alluded to throughout, there are a whole bunch of useful links within the toolkit to generic business case, links to some existing FLS coordinated job descriptions, a lot of links to the Capture the Fracture program. And I know Dave Marsh would want me to say also a lot of links to the second edition of the Orthogeriatrics textbook, which was published in August and has had a lot of downloads since then. So we're nearly there, folks, and then we can go into the panel discussion. So that is the clinical toolkit. I'll now briefly make reference to the FFN policy toolkit. So this is a separate document. And thanks to all of the colleagues that have had input to this. Pillar 4 of the global call to action is how do we assemble multidisciplinary national alliances to advocate policy change to support implementation of the 3 clinical pillars? How do you speak to government with one voice? And that's what this is all about. It is clear that producing consensus guidelines that set clear standards and enable benchmarking of care is critical. That's speaking towards registries and to expand education and research programs that can establish best practice. Here is an outline of the policy toolkit, again, with thanks to UCB for the unrestricted grant to support us to develop this. The Health Policy Partnership in London did a wonderful job of interviewing numerous colleagues around the world to learn from their experiences in driving policy change, what matters, what engages policymakers. There are, in terms of content, 5 key components are identified and a lot of practical resources, particularly with case studies from 8 countries that describe positive experience. It is quite interesting how there are some very, very common themes shared across those countries in very different parts of the world. Again, we're looking to have that translated into Arabic, Mandarin, and Spanish. So to conclude, if you go to this part of the FFN website, so it's www.fragilityfracturenetwork.org/CTA for call to action, then there you can download the clinical and policy toolkit, and there are links to various other useful resources. So I'll leave that, and I would ask you all now, put that into your phones, put that into your computers so that you can download these resources immediately after. The resources, the toolkits are also in the resource center for this meeting. So you can look at that later on too. And here is an evaluation form. I will be reminding you of this at the end of the meeting. And so there, and with a slightly dry throat, I'm going to stop sharing and hand back to Dave Marsh. Thank you very much for your time.
Thank you very much, Paul. Okay, so we've now got Andy and Kasim back online here, and we will wait to get some questions from you, the audience. So please use the Q&A function at the bottom of your screen there to submit any questions. But in the meantime, to start things off, I'd like to raise a question with Kasim and Andy about, you know, workforce development, basically, about how you can, I mean, we've heard an awful lot in this meeting about the desperate epidemiological predictions for the numbers of fractures that there are going to be. And it's an overwhelming number. And if we want to make an impact, we're going to have to apply secondary prevention to all of them. And there simply are not enough endocrinologists, rheumatologists, geriatricians in the world to do that for every patient. There are far too many patients. And the solution to this is what the FLS model is all about, isn't it? It's about having a coordinator, usually a nurse. But we are now talking in a region of Europe, the southern European region, where nurses just don't have that kind of autonomy as they do in parts of the north, like in UK or Scandinavia. So my question to you two, and I'd like you to answer it in terms of the FLS Academy project that you're co-chairing together, is how are we going to persuade colleagues in the south of Europe that it is okay for a nurse functioning under the supervision of an osteoporosis doctor, working to a protocol to manage quite a large proportion of the fragility fracture patients who need secondary prevention, just so that the volume can be dealt with? Andy, do you want to start there?
Yeah, I mean, to me, it's about standardization, and that's what we're trying to produce, I guess, at these meetings, and certainly with the FLS Academy network, is that you've got, and what Paul's really just spoken about, we want to roll out something which can be applied universally. So we know there's not enough nurses. There's not enough nurses in all aspects of medicine. We spoke about this at a previous talk earlier this morning. If we look at theatre nurses, there's not enough theatre nurses. So we're not going to get a whole load of more personnel often. That's what we can do, is expand what each of those people can deliver. So to me, it's about developing online platforms where people can access the appropriate information. That information is standardized. It can be easily applied. It doesn't need somebody, it's not perceived that it needs to be somebody that's high up the medical food chain, as it were, to deliver it. It can be delivered by your nurse. And that person is part of a team. And Paul's alluded in his talk about who the kind of people that should be in that team. And that's, to me, the way forward. We've shown during COVID, for example, that we can do this, that we can do a symposium where we can sit at home and deliver something which is effective. I've seen that in my own job in the Northeast as an orthopedic surgeon. A lot of the management stuff and decisions that I've been involved with can be delivered remotely. So we have to do the same. How you then do that on the ground, I guess you do need people there to make sure that the patient's investigated and treated appropriately. But I think that's where we have to start, Dave, if we're serious about massively expanding numbers of patients treated and found.
So, Kasim, what would you say to a skeptical doctor to reassure him or her that a nurse is capable of doing the FLS function?
I think there's probably two approaches: there's the top down and the bottom up. So the bottom up, working with Julie Santi-Tomlinson and Andrea Marquez, we're actually developing a global competency framework whereby anyone can apply, and we'll set out clear learning objectives and competencies for what is a good FLS practitioner, alluding to Andrew's point of quality, making sure they're safe. Clearly, we have to map to the regulatory requirements within the country. And I think the purpose of the FAN or FLS Academic Network is to develop in each country sort of hub mentors who can then develop a community of practice. This is a team effort. And what we found very successful in the UK is having regional FLS clubs or even smaller than the national models. And by educating and upskilling and sharing resources around FLS, quality improvement, the IQ and QI, as Paul mentioned, we can then ensure quality all the way down. And just touching on Andrew's point on COVID, I think the decision may soon be taken out of the hands of the doctor. We're developing a calculator that shows you the benefits of secondary fracture prevention, but it also tells you how many staff you need. The policymaker will see this and say, well, how do I implement this? And they don't really mind who does it as long as the job's done, because they're looking at it from a financial perspective. And there may actually be a top-down directive to say, actually, we agree there are regulatory issues, but to deliver this, it's too expensive to use doctors. It makes the model unsustainable, in fact.
But is there a risk, Kasim? I mean, is there a risk that a nurse-led service will miss things, will fail to respond to something that an endocrinologist would have spotted in a given patient, and to the harm of the patient? Is that a real risk?
I actually will push back on that quite strongly. We've been running an FLS for 8 years in the UK, and the nurses follow agreed pathways. Not every patient who has a fracture is managed by the FLS, and there are clear exit strategies. And there's also a clinical lead. So if there is an issue, they can discuss with the doctors. We overestimate the ability of doctors to systematically deliver care. Variation of care is very well known, even with orthopedic surgeons, David, in your own field. You know, we overestimate how good we are. And if I had to put my money on it, nurses win, or even healthcare practitioners, others such as physios, rehabilitation nurses, even pharmacists. If they're following an agreed algorithm, 80% of the patients can be managed with a no-touch technique with medicine, with doctors, and the 20% that do need clinical consultation, as long as there's a way where the practitioner can ask the endocrinologist, I've got someone with unusual lab results or an unusual comorbidity, that's your safety net. And I wouldn't think of it as an either or. I think of it as an integrated network that's got a really wide reach. We see 3,500 patients a year. That's more than I can see in my clinic in 5 years.
Yeah. Okay, well, we've had a question from Andrea Marquez, who you already mentioned as being another member of the FLS Academy project. You mentioned, Paul, the role of patients in the patient groups and carers in the preparatory phase. She's asking, what is their role in the expansion phase?
Oh well, I think it's ongoing. Yeah, I took that as read, is that when one has established that multidisciplinary team in the preparatory stage, when you go through expansion, if anything, the team might expand further. But absolutely, the patient voice has got to stay there throughout. I know this is something that Kasim and Matt have done extensively in Oxford with patient engagement. I think it will be a complete anachronism not to do that. Kaz?
I completely agree. The patient is part of the quality improvement team. And also the carers, because we mustn't forget, fracture patients are 50-year-olds with a wrist fracture and 95-year-olds with cognitive impairment and a hip fracture. So we need to include the entire patient experience, and that's how you deliver it.
And just on that point, Dave, as I said in my answer, I typed an answer to Andrea there. It's about qualitative data, because what we've shown in certainly other types of fractures is that what's important to the patient may be different from what we consider to be important. So we really need to, they must be involved in terms of determining, in terms of rehabilitation and getting everything going, what is actually what's important for them and also their caregivers and family.
And perhaps following on from that, we've had a couple of questions. We've had a question from Mira Amr, a physiotherapist from Palestine, saying, do you believe that a nurse with the help of other therapists might be able to help more and save the time and effort for everyone? And then Diana Calcraft came in and said, many FLS nurses are independent practitioners and have a master's qualification as such, sort of reinforcing that. Paul, what do you want to say about that?
Yeah, well, before I left the UK in 2011, I was in the group at the University of Derby, and Derby ran a postgraduate certificate and a master's program exactly for this, for nurses. And indeed, many of the very well-established fracture liaison nurses across the country did that qualification. So I think it's something, I think Andy and Cass have alluded to this, and Paolo Falacci and Stefano Eleuteri's great work with the FFN Education Committee is there's something we could really think about here, internationally, to try to galvanize that kind of thinking. Down here in Australia, I don't know whether Robin Sperrin is on the call, but some of the nurses in New South Wales participate in the quality certification assurance program run by the Royal Osteoporosis Society in the UK. So I think this is something that FFN and with IOF, of course, and the various nurse groups could really take on to say, how could we cultivate that sort of international mindset of formal accreditation for these professionals?
Yeah, I remember being involved in the creation of the when it was the National Osteoporosis Society in the UK, their web-based learning and then accreditation system for fracture prevention practitioners.
Yes.
Didn't have to be a nurse, but a lot of them were nurses. I mean, do you know, Cass, are they open to international clients?
Definitely. So this is on the Royal Osteoporosis Society. You go to the FLS resources. It's under the FLS practitioner, fracture prevention practitioner, and you can do the entire course for free. And if you want a certificate, you pay the nominal amount of £50, and then you want to register. The work Andrea and Julia are doing are to actually globalize this into a set of standards or competencies that can then be nationalized in each country. One of the major drawbacks of the ROS Path package is it's in English, and it's kind of slightly hubris of us to think everyone who's in FLS speaks English as well as we think, as well as we do. So we are developing global competencies that will then allow national societies to develop their own toolkits for content and format and evaluation.
Had a great question here from Maria Panurja, who says, with our patients becoming more and more old, some above 90 years old, should we be looking for a special pathway for this category of patients, i.e. above 85 years with frailty level moderate to severe, since their life expectancy will be shorter than the benefits from secondary prevention treatment? So, is it worth treating older patients?
Yeah, I think that's a really interesting point. I mean, Dave, as somebody who's relatively new to this, it depends. Obviously, if you can get very effective treatment, would be starting treatment as early as possible. So that 50-year-old with a wrist fracture rather than the 85-year-old with the hip fracture. But I think it's still effective. So I would say, I don't think we need to alter the pathway. We still need to initiate the treatment, and the KPIs that Kaz has published on about that still needs to apply to that elderly group, in my opinion.
Before I hand that question to Kasim, I'll just supplement it with a question from a geriatrician in Greece. I didn't think they had any geriatricians in Greece, but they've got at least one, Evridiki Kravariti, who's thanks you for the excellent presentation, and he's planning a pilot of an orthogeriatric FLS in a university hospital in Athens. We are not sure how to handle patients with very poor 1-year overall prognosis, patients with dementia, chronically bedridden or centenarians, in terms of inclusion in the FLS registry and performance indicator quality improvement results. Any advice? So here we go again. Is there anybody who's too old or too decrepit to benefit from secondary prevention, Cass?
I would say these people need faster treatment, not less treatment. The treatments take 6 months to work. I often get the question about bedridden people. Don't forget, you don't need a fall to have a vertebral fracture, and vertebral fractures are very common, and age is the biggest predictor of fracture. I think it would be ageist to argue otherwise. And do remember, it's very hard to predict when a patient is going to die. The clinicians among us will all be used to this when a patient says, oh, how long have I got left? Or how long has my mother or father got left? And we have been schooled by experience not to give a date, because most of the time we get it wrong. And even the Nottingham score for predicting death or mortality after hip fracture has a reasonable performance, but it can't be used at the individual level. I mean, David, would you agree with that? It's hard to predict who's going to be alive at 6 months in some cases.
Yeah, I mean, I think you do have to face up to the question of whether, you know, for that person, that patient, the treatment is worse than the disease. You know, I mean, it's the cost benefit aspect of treatment. I mean, is there any patient group who, you know, discretion is the better part of valor, and you should not be treating?
So for sure, for severe renal failure, expected mortality of 3 months or weeks, then there's no benefit. It does take time for these treatments to work, but they're in the minority of patients, and you know, we're treating more and more now because they just come back with another fracture that does kill them.
I mean, Andy, it would be rare for the orthopedic fraternity to not operate on somebody just because of their age, wouldn't it?
Yeah, I mean, the age thing, as you know, it just varies. You know, it's about comorbidities. It's the level of comorbidity. You know, if you actually get to 85 or 90, you're actually, that in itself means that you're pretty good. You know, especially if you're from the northeast of England. You know, the bottom of it is it's things like the level of comorbidity. That level, we know that that's proportional to how you go on at the end of the day. So yeah, I mean, that's where I would come in.
Okay, well, let me give you another question from me. Of you know, the thing that I mean, Kasim knows how frustrating this has been, involving primary care in the long-term management of these patients. I mean, the ironic thing is that until you have your first fragility fracture, you do not know that you've got osteoporosis, and you probably won't know that you've got a tendency to fall. And then suddenly you're struck by lightning and you get a fracture. And it turns out that is a fragility fracture, and that means you need preventive treatment for the rest of your life. We can't do that in the hospital, whether we're employing nurses or anybody, can we? We just can't have an accumulating massive number of people coming back for constant follow-up. So primary care has to be involved, and certainly in the UK, we've struggled with that, haven't we, Cass? Getting, you know, they just think that blood pressure and kidney function and mental deterioration are sexy and interesting, but osteoporosis isn't. What's the way forward for that? What's your perspective on that now?
So there's probably a couple of ways. One is to use that. So if mental health or dementia is their priority, just make sure it includes fracture prevention, because we know that both dementia and other conditions have a high fracture risk. So use what's already there and make sure you link it in there. And the other thing is not to focus on the GP or the primary care physician. The primary care team is now much more expanded, and there is active work to actually get the pharmacists to deliver this. This is a pharmacological problem of adherence. A clinician or a nurse has already said you need treatment. So it's not a clinical decision making, it's basically ensuring the clinical decision is translated into long-term adherence. And there we have an opportunity, because pharmacists know about the drug, they know about the side effects, and they know there are other drugs. And they're used to talking to patients in a sort of non-clinical setting when they come and pick up their medicines. So we think in the UK, that's a really big push. So we're developing a set of tools with companies and also with the Royal College of Physicians and the Oxfordshire Academic Health Sciences Network to actually shift the focus from the GP, who's completely drowned with everything going on, especially with COVID, to the pharmacist, and empower them to do some sort of treatment adherence.
We've had a follow-on question from Mira, the physiotherapist from Palestine. Would you say that an exercise program is a total necessity of the FLS, or would a home program that guarantees a required amount of physical activity being done every day with the help of family members or other healthcare providers might be sufficient? So I guess she's assuming that we all agree that exercise is necessary, and the question is, should it be delivered by the FLS or should it be delivered in the community? Andy, do you got a thought about that?
I would have thought, again, if it's about providing infrastructure and information to the patients in an adequate fashion, so I would have thought a home-based one that's tried and tested would or is certainly a good starting point. Again, it's about numbers. If you can't deliver the sort of gold standard home service with somebody going and visiting the patient, then they at least need to get that information in a program that they can start at home. So that's certainly a good start.
I'd love to be able to ask Mira what the situation is in Palestine, whether they can sustain a long-term supervised exercise program. Paul, you had a comment.
Yeah, well, actually, down here in New Zealand, we've had a big program with government that back in 2016, after a really concerted lobbying effort, we went from practically zilch FLS to FLS in all of our district health boards. But another key component was a big investment by government in-home and community-based strength and balance programs. I'll put up on the chat board a link to that program, because colleagues from elsewhere in this region have found that quite useful. It's called Live Stronger for Longer. I'll do that in 1 second. Just coming back to a point that you were discussing earlier about this critical issue of primary care engagement, something we're trying to do here. We tried to do it in the UK, it sort of got off the ground, but I think we all need to revisit, is national osteoporosis societies and national colleges of general practitioners coming together to look at how could we jointly develop properly accredited education programs for primary care doctors and primary care teams, specifically around secondary prevention.
Yeah.
I think also, Dave, can I just say on that point, though, almost at the opposite end of the scale, I mean, as somebody who's an orthopedic surgeon who's really just got interested in this in the last year, what struck me is that this is actually really interesting. It's about educating, communicating, and generating data. So I would start really small, actually. You know, the individual primary care practices, the GP practices within that could have an osteoporosis champion. And we as doctors have to communicate what we want in terms of secondary fracture prevention back there effectively. I mean, I'm now doing that because I've got involved in this and actually realized the benefits of it, you know, having done orthopedics for 20 years. So we don't communicate effectively to the GP practices. Once we get them interested in it and put it on their radar, then they're going to respond. The thing is, at the moment, we're not doing that. I know we're not doing that because I've been working in the service the last 20 years, and we're not getting that information to them properly and effectively and generating their interest. So start small, you know.
An interesting thing that applies to Southern Europe in particular, because there's quite a lot of physiatrists in the Southern European countries, more than geriatricians often. And one thing that it strikes me physiatrists are pretty good at is the smooth transition between inpatient care and long-term community care. And I think places like Greece and Spain and Italy, where there are a lot of physiatrists, I think they could be the champions of welding the community medical community to the hospital one in a joined up sort of a way. Well, I think my brain is full, and we should therefore stop. But it's been a great discussion. Thank you very much indeed. And I hope everybody will go away charged with enthusiasm to develop FLS in your own country. Thank you very much, everybody. Goodbye.
Thanks, David.